So first of all, I'd like to thank Manos and Manos for inviting me to this course. It's getting better and better every year. I've been here 20 years ago and Manos was still doing the courses in the university, and every time enjoy coming again and again. Thank you. So just again, going back to last year, there's a few pictures here. I'm working in Reading. Reading is the big city just west of the village called London. And I work as well a bit in Israel as well. This is my disclosures. I'm the designer of the prosthesis we're going to talk about. So development of shoulder replacement and the origin of the design of the stem started with Emil Pean for infection, from Stenmore for tumors, and then the hip that converted to shoulder. And then Charles Neer on the other side of the Atlantic developed the shoulder replacement to deal with fractures where he needed a stem for a scaffold for the tuberosities, but none of these were developed for arthritis. And my mentor and late colleague, Steve Copeland, was a game changer when he introduced the resurfacing, and there's many papers by us and others that shows very good results with resurfacing, and to be honest, the world has changed since then, because now you can see resurfacing and stemless all over. So, but it took us about 20 years to persuade the world, to convince the world that long stem is not necessary. And then the tests and the clips came on, and they showed comparable results with all the third and fourth generation of standard stem prosthesis. And then the others came along, and actually there's a lot of stemless prosthesis now that shows good results in the anatomic shoulder. The reverse shoulder is gaining popularity, and we heard it here, and we know. And in 2018, more than 60% of the shoulder replacement in the US, in UK, in Germany, Italy, Israel are reverse. In the NGR, the Australian NGR, it was 73%, and in France, I think more than 80, correct me if I'm wrong, and it's getting more and more all over the world. However, there are problems with the stem, and we heard already today, and we have glenoid notching, we have stress shielding and disappearance of the tuberosities and the proximal humerus, limited rotations and periprosthetic fractures, dislocations, revisions, and more worrying is actually the significant reoperation rate. And Buddy already alluded to that. To do an operation like that is not simple. You're not coming out satisfied after doing a revision and removing a well-fixed stem. So Pascal Boileau showed about 22% of reoperation of reverse in primary calf arthropathies, and up to 60% in revisions and rheumatoids. And you can see here, this is a graph from Brad Edwards in 2014 from the ASES of the revisions of reverse arthroplasty. And to remove a well-fixed stem, it's really a difficult operation. And we see recently revisions with longer and longer stems and less bone stock. And I ask you guys, what next? Anyone has got an idea what to do next? To chop this guy's arm, to chop his head, what's next? And this is only the tip of the iceberg, because we see a lot of this stemmed implant going in. And as Buddy said, thank God I'm a bit older, so maybe you will have to deal with the revisions. But we have to have a different approach, a different attitude, and see the patient or the shoulder of the patient life journey, and think about the future and how to follow the patient for the rest of his life, and the importance of bone preservation. So with that in mind, we designed many years ago, we designed the Verso, which is a triple fin stemless metaphyseal reverse prosthesis. We've got now more than 14 years of clinical experience since 2005. The principles are minimal bone resection, bone preserving prosthesis. It's a stemless metaphyseal fixation with a cancellous only fixation, cancellous bone only fixation. There's no diaphyseal stem, and it's a cementless fixation with bone impaction techniques. We can do it in any bone. So just to make things correct, I mean, people say, oh, it's a short stem. It's not a short stem. This is a stemmed implant, okay? Definitions. This is a short stem because there is a stem going to the diaphysis. This is a stemless metaphyseal prosthesis, and you can see it's only 3 fins that goes into metaphysis. So that's now the definition. Now, the stemless design is important. Not all the stemless are the same. And it should be a stemless that has a good stress distribution to the metaphysis. It should have immediate fixation and stability in the bone. And again, the idea is that it's got a large surface area to volume ratio. So we have a good fixation into the bone and good stress distribution. So we actually, because it's only 3 fins, we introduced a few new concepts. It's the total metaphyseal cancellous only fixation and the bone impaction technique to enhance the bone stock. So you can see here, I use the head that I resect and mesh the bone and insert it into the proximal humerus. And sometimes I have to use the whole bone that I have there. And sometimes I have to use bone graft substitute because I don't have enough in revisions. And then after impacting the implant in, and you can do it several times to impact the bone in, you can see that I'll try it now, it is really rock solid. And with a hydroxyapatite coating getting even better. So between 2005 and 2018, so up to 14 years experience, we had 676 patients, where 587 of them were stemless and 81 were with stemmed, and these were mainly revisions from other stem implants or acute fractures where you need a stem. And you can see the distribution. Actually, 70 of these prostheses were revision cases, and some of them we managed to revise from a stem to a stemless. I just want you to see, it's the second patient. Look at her rotations, like the previous patients. Again, the previous speakers talked about rotation, that you don't get good rotations with reverse shoulder. Just look at the rotations, because we'll talk about it in a minute. And we looked at the bilateral patients, and none of them had any problems with activities. Again, the rotations improved as well, and here you can see this 79 years lady with 9.5 years following that. Again, excellent rotations, active external rotation, active internal rotation. And these results have been maintained over the long time. We have a computerized database. We keep it very, very strictly. And actually, you saw the long list of fellows that I mentioned in the beginning, and I want to give credit to them because they are very meticulous in following all the patients. And you can see, we couldn't see any deterioration of the results. And you can see again, bilateral AD with her range of movement. Again, most of the patients, 95% of the patients, shows excellent rotational movement as well. Radiographically, we haven't seen any lucencies around the implants. There was no glenoid notching in 520 of them. In about 20% of them, we had notching, but mainly grade 1 and 2, and very few we had grade 3 notching, and these were usually when I used initially the retentive liner, which I stopped using anymore. Again, you can see with the Verso, we didn't have any subsidence, no loosening, no stress shielding, and no lysis of the tuberosities. Now, stress shielding is a major problem, and we know that we hear more and more about it, and that's a major problem, and what do you do if you have to revise it? And I was surprised to see that even the short stem, the Ascend, the Tournier Ascend actually showed in less than 2 years severe stress shielding of the great tuberosities and all that. It's a paper by Tom Norris, and then there are some papers, other papers as well. And we haven't seen that. And I think maybe it's because we have only cancellous fixation and good stress distribution. Now, there's other things about the cut. The cut is 155 degrees, but we have this angled liner that we can adjust. And with that, we get 145 degrees angle. And you can see that by doing that in the red arrow, we actually clear the space for impingement-free movement. And that's one of the, I think, one of the reasons we get such a good rotational movement, because we can even actually adjust the version correctly to every patient the last minute after we put all the implant, the metal implant in, as we can dial it to the right version. Complications, and we had some complications. We had a couple of cracks of the humerus. This was initially, again, maybe too much bone in rheumatoid patients at bone impaction. We put some PDS cord around, treated them a bit more conservatively, and all healed. Haven't seen any problems or subsidence or loosening later. One glenoid fracture, again, as we managed to fix it properly, again, treated conservatively, and it healed, no other problems. In this series, we didn't have any further problems. We had a dislocation, and you can see this gentleman, again, it's a soft tissue problem. One of them was, one of the patients pushed himself out of chairs at 1 week after surgery and dislocated the shoulder. We learned to tell them not to do it. The second one, this guy that you can see here, that is now 7 years after, he had a tightness of a band of soft tissue, and he hinged his shoulder out. Again, we had to revise. None of them was specific to the implants. Again, fracture of the acromion, again, we know that this is not a problem. 6 traumatic scapular spine, these are difficult to treat, whatever we do. And glenoid fractures, again, patient fall, and you can see we could revise it easily as well. None of these are actually due to specific to the stemless implant. Rheumatoid patients, the results were very similar to the results of the cuff arthropathy with our prosthesis. Again, I don't know to explain that, but the results were very good with the rheumatoid as well. Younger patients, it's a major problem, and again, we have in the younger patient results that are very similar to the old age, and actually, again, the major advantage of this implant is mainly in younger patients. You can do it with a stemless prosthesis. And here, this is the youngest patient that Steve Copeland did a resurfacing. He did a total resurfacing when she was 22 years old. And here she is, 45 years old, still very young. 23 years after the resurfacing, you can see that she lost all her cuff. The cuff is gone. And what do you do? She's 45. So I revised that to a verso. And this is here, her, 6 years down the line. She's still very young, 51 years old. And she's got the best range of movement she ever had. I don't know if this will last for the rest of her life, but if not, I've got all the bone stock there to be able to do something else. And most of the patients are returning. Most of the patients are returning to sports. Some of them nicer sports. Some of them are more crazy, like this guy who's playing ice hockey international level for seniors, or my craziest one, the jumps out of planes. When I first saw that, and my fellow told me he's doing this skydiving, I said, not with my shoulder. Imagine how much power and force going through the shoulder. And he said, Prof, I will do it whether you allow me or not. This is my life. I said, okay. So that gave me some pictures. I said, but by the way, you improved my technique. I said, how come? I said, before that, I couldn't open my arm. I would go down in spirals. Now I can fly. So I don't recommend it for improvement of flying. Our good results are supported by the good results with the test. The test was introduced about the same time, but just a word of caution, because the test, actually in more than 80% of the cases, they used it with a stem, because they did the thumb test, and if the bone was soft, they used to put a short stem. And this is a paper from Philip Moroder that show that. And just to show you in contrast, this guy with an eggshell proximal humerus, there's no bone whatsoever, okay? I actually impacted, grafted it with bone graft substitute, and you can see that this is healed. I filled up his bone with new bone. Now, you could have argued that he's 89, who cares? You can put some cement or whatever. But this makes the case. If it works in this case, it works in any case. Again, another advantage of the stemless implants are periprosthetic fractures. We live on planet Earth, there's gravity, and these elderly patients fall. And if they fall and they have a stress riser in the middle of the arm, they will fracture. Which one you prefer to treat? The one on the left or the one on the right? So it's a rhetorical question. And most of our patients we could treat conservatively, like this lady. It healed. She's got functional range of movement. She's 88. She can do whatever she wants. Again, she didn't have to be operated again. And only in 2 cases, we had to revise it when it was completely displaced, and we revised it to a stemmed implant. There are limitations for stemless. Stemless is not good for everything. So if you have acute fractures, non-unions, severe bone loss, or sometimes if someone else been there with a long stem and you can't preserve the proximal bone, you need a stem.
Ofer, I'm sorry, you have 30 seconds.
Okay, I'll finish. So then you need a stem, and this is, you use a stem. So just to show you the journey, this guy had infected shoulder, Steve Copeland did the resurfacing at the age of 41. He had a cuff tear in 97. I did the cuff repair at the time. I wouldn't dare to do in the age of 58 or age of 47. Reverse at the time, a delta. At the age of 48, he came with this movement that you can see here. I revised him to a verso. That's 7 years later. He's 65 here, very, very happy. And actually, this is 11 years after revision of a surfacing to reverse. Again, you can see he's very happy, good function, no loosening, no subsidence, good x-rays. And just to conclude, the stemless reverse shoulder shows excellent long-term, more than 40 years, clinical and radiological results. It's bone-preserving. Its outstanding range of movement include active external range of movement, active external rotation and active internal rotation, long survivorship, no loosening or subsidence, and better revisability. Thank you very much.